Thank you very much, Geneviève, for this kind introduction. I'm very happy to be here with you today. So here are my disclosures. And as an introduction, I would like to remind you some words about RSV disease burden. I think you all know that RSV is a major viruses public health concern. In the right here, you can see in this graph the number of severe RSV-associated cases in several European countries last year. And as you can see here in green, the vast majority of severe cases occurs in children, particularly those less than 6 months. It is estimated that each year there are more than 3 million hospitalizations in these children, more than 100,000 deaths each year. And importantly, recent studies have also shown that if you have lower respiratory tract infection during your childhood, this is associated with an increased risk of premature adult death several decades afterwards. So this is also important to keep in mind. And importantly, RSV severe diseases is also associated, seen in adults and immunocompromised patients. We've already talked about that. And just giving you here some recent work, meta-analysis performed in adults aged more than 60 in high-income countries, including the US, European countries, and Australia. And as you can see, there is more than 5 million cases of RSV occurring each year, leading to 465,000 hospitalizations and 33,000 deaths. So for these reasons, and for the reason of RSV severe disease in children, there has been substantial research and development pipeline for prophylactic and therapeutic products against RSV. But before going through these prophylactic and therapeutic approaches, just a few words on the virus. I think you know that the virus belongs to the Pneumoviridae family. It is also metapneumovirus belongs to this family. It can be divided, and Carlo Federico has already talked about that, into two major antigenic groups, RSV-A and RSV-B, that usually co-circulate in each season, that could be further divided into other genotypes. And as you can see here on the right, there is a representation of the virion with two major immunogenic glycoprotein, which we call the G protein and the F protein. And in contrast to G protein, which is highly variable, the F protein is much more stable. It represents more than 90% sequence identity between RSV-A and RSV-B, and this is why F protein is thought to be a good candidate for vaccination and for immunoprophylaxis. So focusing on the F protein and its impact, its implication in viral entry, you have here the several steps for the viral entry. The first step probably is the attachment of the F protein in its pre-fusion conformation. Here, through several attachment factors, some have been identified, but not all of them. And then once this attachment occurs, you have a refolding of the F protein in its post-fusion conformation, which is actually pre-herpin intermediate, similar to what we know with HIV entry, actually. But this is quite theoretical because the pre-fusion conformation is actually unstable. And it has the propensity to prematurely refold into the post-fusion conformation, which is much more stable. And this has implications in terms of antigenicity, because several years ago, when the pre-fusion and post-fusion conformation have been defined, have been characterized, it has been discovered that the pre-fusion conformation has two antigenic sites. You can see them here in red and in orange, site 0 and site 5, that are not present in the post-fusion conformation. And importantly, these two sites induced highly potent neutralizing antibody responses, the most potently antibody neutralizing responses, actually. But because the pre-fusion conformation is unstable, where during infection there is a low amount of generated highly neutralizing antibody, this is a kind of conformation evasion from the virus to immunity. So if you want to have a good vaccine candidate, we will need to stabilize F protein in its pre-fusion conformation, which make transitioning to the post-fusion less favorable. And this can be achieved through several changes in the F protein. And there are at least two major changes that we can do so that to stabilize the vaccine. First, there is a large cavity, internal cavity in the pre-F. And if you introduce mutation called here cavity filling mutation, this is the first step to stabilize the pre-F. And also, if you introduce disulfide bond between some cysteine residues, this further stabilizes the vaccine. And currently, this structure is the basis for all future, nearly all future vaccine candidates. So this was performed in 2013, and mainly 10 years afterwards, that we have now the results of several exciting, promising pre-F vaccine candidates that have shown really good result to prevent RSV severe diseases, particularly in the elderly, and that has led several researchers to think of RSV illness in the young and in the adult as the beginning of the end. So what are these promising pre-F vaccine? There are at least 3 vaccine candidates, one from GSK, Pfizer, and Moderna. GSK uses a recombinant vaccine, and Pfizer as well uses a recombinant vaccine. And Moderna uses the mRNA technology, of course. The population target is for these 3 vaccines, the elderly, meaning patients older than 60 years, and as you can see, efficacy was really excellent, more than 80% efficacy against lower respiratory tract disease. In addition, GSK and Pfizer had just been FDA approved. Pfizer 1 week ago was FDA approved, and EMA approval was also given to GSK. So in addition to the elderly, Pfizer has also shown good results to prevent RSV in pregnancy, in pregnant women, to avoid RSV severe diseases in their newborns within 3 months after birth. However, there might be some concern about safety, and further analysis are needed in the next coming weeks on preterm births. So in addition to vaccines, there are monoclonal antibodies, really good, exciting results with monoclonal antibodies targeting F. First, just a few words on palivizumab. You probably know palivizumab, which is available now for 30 years. It's the first humanized monoclonal antibodies ever tested, actually, in infectious diseases. Since 1998, it has been used for prophylactic use to prevent RSV-associated hospitalization in high-risk infants. It is safe, it is well-tolerated. The problem with palivizumab, which actually here targets SAI2, is its cost, and it requires monthly intramuscular injection of the RSV season, so up to 5 injections each year, and so we need to face logistical and financial barriers. And the new revolution comes with the new long-acting monoclonal antibodies, starting with Nirsevimab. So Nirsevimab actually targets site 0. Remember, site 0 is the site, antigenic site, that induces the most potently neutralizing antibody responses, and indeed Nirsevimab induce more than 50-fold higher activity as compared to palivizumab. Importantly, as it has been shown for SARS-CoV-2, when you introduce some amino acid substitution in the IgG constant Fc region, that increases the half-life of the monoclonal antibodies, and therefore only one intramuscular injection is required prior to the RSV season with Nirsevimab. And so Nirsevimab has been tested in clinical trials for the prevention of RSV in newborns. Actually, it showed really good efficacy not only in preterm but also in term-healthy infants, showing more than 70% reduction in RSV diseases with a favorable safety profile. And importantly, a few weeks ago, we had this press release from the Harmony Phase 3b real-world clinical trial, which included more than 8,000 infants that were either received a single dose of Nirsevimab or that were in the non-treatment, non-prophylaxis strategy, and which showed 83% reduction in hospitalizations. So for these reasons, Nirsevimab is now approved in Europe and Great Britain for the prevention of lower respiratory tract disease, not only in preterm patients, but in all newborns. But of course, there is cost-effectiveness data that is needed to discuss with countries and with the use of these antiviral prophylaxis. So in the first conclusion regarding prevention, there is a huge hope today for RSV prevention, not only for infants through their first RSV season by long-acting monoclonal antibodies, but also in the elderly with the vaccination availability soon. Some remaining critical scientific questions, however. For the elderly, the greatest benefit has been shown to reduce lower respiratory infections, but we don't have data regarding hospitalization, regarding death, or more data are needed regarding that. Can monoclonal antibodies be used in the elderly and in the immunocompromised population? As for the moment, it's only used for infants. Regarding young infants, could maternal immunization, provided safety concerns are raised, could be used as a complementary approach with monoclonal antibodies. And of course, in the future, we will need to surveil for viral genetic diversity of RSV in the context of using monoclonal antibodies. So the second part will be on RSV therapeutics, and actually it's much less advanced because today the only therapeutic option for RSV is ribavirin. And you know, all ribavirin is toxic. Ribavirin has been used for nearly 40 years, and they are mainly in the immunocompromised population, either patients with hematological disorders or patients with lung transplants. Its efficacy is still controversial. There is this recent meta-analysis in patients with hematological malignancies and hematopoietic stem cell transplant recipients, more than 1,125 patients, showing that ribavirin could be used as an option to treat RSV in patients with hematological disorders, but with moderate certainty of evidence. But in the absence of other effective antiviral agents, well, we don't have really the choice. The future might bring, however, some promising direct antiviral agent candidates. And here you have a representation of the RSV life cycles. And these DAAs target several steps of the viral life cycles. First, fusion inhibitors. Then you have inhibitors of the replication step, particularly the polymerase, and finally inhibitors of the nucleoprotein. And the fusion inhibitors are actually the most developed, the most promising, or the most developed at least for those direct antiviral agents. Here you have a representation of these small molecule fusion inhibitors with the pre-fusion conformation. You have the side view on the left and the top-down view on the right. And you can see here these small molecules binding inside the central cavity of the prefusion conformation. And actually, there are several compounds, several candidates. You can see here they all bind the same pocket, and they have all the same mechanism of action. Prezatovir was the first of these agents showing good results in an RSV challenge study, meaning healthy adults who receive a clinical challenge strain of RSV intranasally. And as you can see here, prezatovir treatment was associated with a lower viral load on the left part of the graph in white as compared to a placebo, and also lower symptom scores in this challenge study. Prezatovir was then tested in clinical care, so meaning in immunocompromised patients, adult patients infected. Here I'm showing you three clinical trials. The first with hematopoietic stem cell transplants with upper respiratory tract infection, lower respiratory tract infection, or patients with lung transplant. The results were, however, quite disappointing because, as you can see in the upper part of the graphs, the treatment did not reduce viral load in these three cohorts, including hematopoietic cell transplant and lung transplant. However, and similarly, it did not reduce the severity of the disease. However, in a subset of patients with lymphopenia in the upper respiratory tract infection group, prezatovir showed a decrease in complication development by day 28. So I may not have time to go through all through all other candidate direct antiviral agents in development. However, I would like to focus on two things. First, generally, human challenge model work well in terms of lowering viral load, in terms of lowering symptom scores. This has been shown for really several studies with several direct antiviral agents. Similarly, good results are shown if you treat rapidly your patients and Carlo Federico has already talked about that this morning, if you treat within 5 days of symptom onset non-hospitalized patients, you can reduce in time viral load, and you will have a favorable impact on clinical costs. However, if you treat late, at a later stage, like for the fusion nanobody used as a fusion inhibitor, then the reduction of time and detectability is less clear, and the impact on clinical outcome is less clear. So in conclusion, for therapy, several remaining questions. Does ribavirin work clinically? It's still not clear, probably in some hematological disorders. Why are antiviral candidates effective in human challenge models, but not in clinical care? And I think we discussed that a lot this morning, the problem of speed, early treatment initiation, so rapid diagnosis will be absolutely required in the future. And maybe we should also think of linking home community diagnostics to rapid antiviral access if you want to have good efficacy with antivirals. Finally, does it matter if you are healthy, elderly, or immunocompromised? Because we have really good results with human challenge models which are healthy adults, but in real care, clinical care, the population is immunocompromised. Is there a need of immune modulation? And if so, which candidate? At which phase of hospitalizations? Before hospitalization? These are questions that need to be discussed. And in the context of availability of future vaccine, will vaccine impact antiviral efficacy? And finally, as monoclonal antibodies will be available as prophylaxis, could they be used as well in immunocompromised patients? So for that, I would like to thank you, and I'll be happy to take some questions.